I've been asked to speak about maternal health challenges and successes with a focus on low-income countries, but I'm actually going to start with a historical example. This is in Windsor Palace, and it's a monument to Princess Charlotte, who was the heir to the throne. She was the daughter of George IV, and she died in childbirth, and as a consequence, that ushered in Queen Victoria in the Victorian era. But you see her going up to heaven with the angels holding her stillborn child with her. And equally, here's a painting from the National Gallery, which shows an earlier period where women, this is a pregnant woman about to go into childbirth, and the portraits were painted because women were afraid they were going to die, and this was a sort of memento just in case they did die in the process. And if we look sort of more broadly, we can see that historically at least, you had very, very high rates of maternal mortality. So if we look at the European nobility from the 1500s, we can see levels of maternal mortality of about 2,000 maternal deaths per 100,000 live births. If we look in the 30s in England and Wales, we see that maternal mortality was around 400, 450, and interestingly, it was the rich that died more. And then at the bottom, you have some of the most recent data we have from the UN that show us really the spectrum of maternal mortality. You have places like Afghanistan, the highest in the world, 1,400 per 100,000. Swaziland that I've picked because it comes right in at about the global average of around 420 per 100,000. And the UK, which is not the lowest, but towards the end of the spectrum. And you can see that there's over 100 times difference between the rich and the poor countries. Now, these are again data from England and Wales, and you can see that the levels of mortality until about the 1930s were between 400 to 600, very similar to what you see in poor countries nowadays, and that those levels plummeted starting in the mid-30s until about the 70s. And historians that look at this think that this coincided with medical technologies, introduction of antibiotics, blood transfusion, management of hypertensive diseases. And for all intents and purposes, I think from a public health point of view, we can say that maternal deaths are eliminated in this country. Of course, there are still women that die, and it's very sad, but we have more men that die of breast cancer each year in England and Wales than women die of maternal causes. Now, the picture when we look globally is very different. In the late 80s, delegates, in fact, at the end of the decade for women, their attention was drawn to the fact that a woman was dying each minute, day in and day out, of maternal causes. And as a result of the launch of the Safe Motherhood Initiative and subsequently the Millennium Development Goals, reducing maternal mortality became one of the MDGs. It's MDG 5. And ensuring that women can give birth with a skilled birth attendant, that is a midwife or a doctor, and can access emergency obstetric care when they have complications is a crucial intervention. And it's one of the skilled birth attendant is one of the targets which is monitored. And this is, again, putting the global level in 1990 and the target in 2015 in the context of the England and Wales data that I've showed you before. So you can see the kind of where the level is now. It's about 420, or it was about 450 in 1990, and the target is to bring it down by 75%. Okay. And I'll talk a little bit about what makes maternal mortality different. So the first map of the world shows basically the darker the color, the higher the level of maternal mortality, and you can see that it's a sort of swathe that cuts across the south. The timing of maternal death is critical. Most women die on the day that they're giving birth or the day immediately afterwards. So although women can die in pregnancy, the risk is highest at the time of delivery or the immediate postpartum. What do women die of? These are data from sub-Saharan Africa, and you can see that the big red swathe, the big red bar at the bottom, that's postpartum hemorrhage. Women are dying because they're bleeding to death. Okay. Now, when we think about this, what does this mean? Well, most of the complications that kill women, and there are 5 of them, hemorrhage, obstructed labor, hypertensive diseases of pregnancy, and infection. These complications are difficult to predict or prevent, yeah? And also to treat them requires some skill. So this is different than, say, breastfeeding, where we can encourage mothers to breastfeed the baby immediately, and that will have an effect on neonatal mortality. These are relatively, they're not that complicated. They're sort of 1950s obstetrics, but they're not things that you can do very easily at the home, sort of no do-it-yourself cesarean sections. So what needs to be done to address this particular problem? The school coordinated one of the Lancet series in 2006, and what we came up with was that we needed to focus on delivery and emergency obstetric care, but also on family planning and abortion services. And this needed to be combined with more attention on health professionals, greater financial resources, robust tracking of progress and accountability, and greater political commitment. So what's happened? Well, I think there has certainly been the greater political commitment. In 2010, Ban Ki-moon launched his global strategy for women and children's health, and there were 3 strategic areas that they highlighted: reducing financial barriers, creating a stronger policy environment, and improving and strengthening health services. Okay, so just to give you some examples of challenges and successes. I think the first issue is about availability of services. These are data from Zambia, and you can see that there are roughly 1,100 health facilities that provide delivery care. But when we start to look at their level of functionality, only about 50, the ones that are labeled CMOC, are functioning at the level of a hospital. That's they can do cesarean sections and give blood transfusions. And of the 1,100 that do deliveries, only about 100 are functioning at the level of even a basic health center and can manage basic emergency complications, so give antibiotics, for example. Many of the services, nearly half, can do nothing except basically provide a room. Yeah. The other issue is really access to services. Again, these are data from Zambia, and it looks at urban and rural populations, and you can see that for urban populations, women are within 15 kilometers of a place that can deliver services, do deliveries, but also the vast majority are close to places that are functioning. The green bar is functioning. But when you look at the rural level, you can see that while 80% of people are close to a place that delivers women, only 20% are close to a place that really can do very much for them. Providers are also a big issue. Here you see data on the numbers of doctors, and the line, the sort of benchmark, is a WHO benchmark about what's needed just doing obstetrics, and the figures you see are the total. And so for many provinces, there aren't even the total number of doctors you need, much less those you need for delivery care. And I'm contrasting this with Sri Lanka, which is a country, a low middle-income country that has very good maternal health outcomes. And you can see there's huge gaps in some parts of the world, particularly in sub-Saharan Africa. Another challenge is poor quality treatment. And what you see here, each of these bars is a woman, and if you look at the bottom one, this is a woman admitted to a hospital in the Ivory Coast with a ruptured uterus. So her uterus had already burst because she'd been in labor so long, and she was in shock, okay? It basically took over 10 hours for her to get care. Largely, it took nearly 2 hours to call a doctor, and then the family were sent out to go and buy supplies, and that's the green and the dark blue bars. Another important challenge are economic costs, and here these are data from some work done by Borghi that shows that even for normal delivery, families are paying up to, for example in Ghana, 5 to 6% of the GDP per capita. Yeah? 10% is considered to be a catastrophic cost that tips family into poverty. And when you look at what they were paying for cesarean sections, so for emergencies or complicated, you can see, for example, in Burkina Faso, it's more than the average GDP per capita. Now, that's sort of some of the challenges. I want to start moving on to some of the successes. There has certainly been a growing move of countries to start removing user fees for delivery care. And you can see starting first with South Africa in 1994, but then again a whole range of countries starting to remove user fees for delivery to address this issue of cost. And this has paid off. So for example, if you look at Ghana, you can see that percent of deliveries in health facilities with a skilled attendant are increasing. And the figure on the right calculates a concentration index, looks at inequality in that, and shows that over time, with a couple of successive policies, the line is moving closer to a line of equality, which means the differences between the rich and the poor are reducing, and poor women are more able to access delivery care. Another issue is poor quality of care. I touched on that with the Ivory Coast example, but you can see these are some data from Lebanon that show that there are poor practices that are very widely practiced, for example, women being tied during delivery, but then good practices like being helped to breastfeed that are not very prevalent. But the services can be improved. For example, in Ayacucho, Peru, we were involved in evaluating a project where they tried to adapt the services to be more acceptable to the indigenous population there. And what they showed was a huge increase in the uptake of this from 6% to 83%, and this was sustained well beyond the life of the project. This was a 3-year project, and even 8 years later, we could still see an effect. Also, on the front of sort of global financial resources, they haven't been adequate, so maternal and newborn health haven't been given this financial priority, even though they have a bigger burden of disease than HIV, TB, or malaria. But global financial development assistance to maternal and newborn health has grown. So it was 563 million in 2003, and it's up to 1,227 million. Very quickly on the last two areas, unmet need for contraception. I think in some ways this is a real scandal because delivering contraceptive services is something that we know how to do and was done, but I think globally we've taken our eye off the ball. There was a whole period from the mid-90s, I think, where people weren't focusing on this issue. And you can see that although unmet need for contraception is decreasing, so this is looking at two different 5-year periods from 1990 to 95 and 2000 to 2005, and the picture is getting better, but I think it's still pretty shocking that a quarter of women who want to be contracepting don't have access, again, in sub-Saharan Africa. Abortion policies are another area. Here you can see the restrictive abortion policies, again, are very much in the global south. In some countries and in some settings, things are getting better, and others are getting worse. So it's not a universally positive picture. But I think it's an area that really, again, is really technically easy to tackle, although politically very challenging. So to conclude, the target, as I mentioned, is to reduce maternal mortality by 75% in 25 years. Is that feasible? I think it is, because here I've sort of transposed those figures, and you can see that in England and Wales, that sort of a decline was achieved in a similar time period. And now we do have better approaches and technologies. We are making progress, so the figure in 2008 in red shows that maternal mortality is coming down, but you can really see we're not quite on track to reach the 2015 target. Individual countries are also progressing, and you can see these are data from low and middle income countries. For example, the dark brown one is Bangladesh, and you can see levels are declining. And just to end, when I was asked to do this talk about Women's Day, I thought, was this really the right topic for Women's Day? Is this a sort of Mother's Day topic? Because I think childbirth and maternal mortality see women in their role as reproducers, women needing care in a very traditional role, burdened and weak. But I think that some of the successes are, we also see women as midwives, as skilled birth attendants, providing care. The women are amazing survivors. I mean, some of these studies we do on women who nearly die, you just sort of think, God, how did they survive these? You know, how did that woman that I told you took 12 hours for her with a ruptured uterus to get care, she survived. I mean, how do they survive? And strong and resilient creators of the future. This I found when I was looking. This was a Russian poster, and it was 8th of March is a day of the rebellion of working women against the kitchen slavery. But I thought for this, I just flipped it around, and I said, today we ensure that other women don't lose their lives giving life. Too many women are still dying in their prime years. Maternal mortality is an MDG that 189 countries have signed up to, and we need to get on with what works. Thank you.
Thank you very much.